Hello, my name is Hidalgo. I am talking about Viremic relapse after HIV1 remission in a perinatally infected child. About the definition, we have the transmission of the infection from the mother to her child can occur in the uterus around the time of delivery or later, as may occur in transmission of microorganisms through breastfeeding. Plasma viremia also remained undetectable through 29.9 months after the discontinuation of the antiretroviral therapy on ultrasensitive single-copy viral load assays. HIV-1 specific antibody and cell-mediated immune response were not detected through 29.9 months after the discontinuation of the antiretroviral therapy, but were detected a viremic rebounding by means of enzyme-like immunosorbent assay.
The case description, I think, was one piece of an evolving story in which we are beginning to understand that very early and vigorous treatment of HIV infection can make a difference. And when I say make a difference, I mean that it appears that by using very early treatment in either children or adults, that we may be altering what we call reservoirs that the virus sets up, and it is those reservoirs that are the barriers to cure. Our case was one of the first descriptions. Of course, the Berlin patient was the very first description, and I think they were helpful because they helped to challenge the idea that lifetime treatment was necessary. This is a very quickly moving field, and a number of other studies have come to light, and those have indicated that very early treatment reduces or restricts the amount of the viral reservoir. May also restrict somewhat the types of cells that are infected, and that may allow us to craft better strategies towards cure. The last time that we followed up with the baby had reached the age of 3, is healthy, and remains without evidence of HIV rebound, and that's about 18 months off antiretroviral therapy. So we've been very happy. In science, one case is nice, but being able to replicate that and to really understand what happened is our ultimate goal. So Dr. Prasad and I, in collaboration with a number of other individuals, have written a protocol which will be implemented through the NIH Impact Clinical Trials Group. And that protocol is right now being finalized in the final state of development. And that will seek to replicate the conditions under which the Mississippi baby was treated. So basically, treatment within very early first day or two of life, 3 drugs, and then we'll look at what we call these viral reservoirs and outcomes. So we're hoping that the protocol will be completed very soon, and we are hoping then that if it can be completed over the next month or so, that it will be open for accrual sometime probably early in the next year.
About the applications in medicine, we have additional studies are underway to test these hypotheses and to determine whether antiretroviral therapy alone will enable longer term HIV-1 remission. Until these studies are complete, initiation of antiretroviral therapy as early as possible in infants and continuation without interruption seem prudent.
One of the first things to come out here today is news of a child in South Africa who has been in HIV remission for 8.5 years, which is big news. Carl, what does this mean to be in HIV remission?
Let's talk about what remission truly means. All remission means is this individual, this child, has no detectable virus in their body as measured in blood, and has been that way for a number of years, as you said, but also there's no medication involved. So the body is naturally controlling this infection.
And so, as I mentioned, this is something that you might see reported in a lot of media today. Is this something that is really big news in the scientific community, though?
So if we think about it from one perspective, a single child may not be such big news, but in terms of the number of these patients we've had over the years, so far we've identified anywhere 3 or 4. We had the Mississippi child, we had the French teenager, and now we have the South African child. And in that sense, are these people, is there something unique about them that will teach us something about the biology of the human interaction with HIV, or are these just one-off random things that we just don't know? So this is where research comes in. Help us understand what's really going on in each of these individuals.
And how did we learn of the South African child?
Well, that's an interesting question. There's been a clinical trial that was run called SHARE, which identified babies at the time of birth that were HIV infected, started them on therapy, and then went through a deliberate treatment interruption at some point. And unlike what happened with the Mississippi child, where it was an accidental interruption, this was a deliberate interruption. This child then, in some ways, was lost to care for a couple of years, and when then they reappeared in care, they were tested and found to have essentially no detectable virus. And the South African researchers have been following up on this child for this relatively new period of time after rediscovering this individual.
And so the child received treatment very early on. Do you think it's that treatment, or is it something unique to this child that has allowed this individual to stay in remission?
So we can speculate on this. Clearly, we basically don't know. One makes the assumption automatically that it's the treatment that did something. But there are other examples of people who are natural controllers. So this is really the fundamental question. Is it the treatment, or is it the genetic and physiological makeup of the individual, and how that individual's physiology and genetic makeup interacts with that specific virus that has infected that individual? A lot to learn.
Great. And the topic of cure has been one that's been very hot here at the conference, and as it got started yesterday and today. And when people hear about a case like this, they might think automatically, this child has been cured. Is that the case? What do we need to take away with regard to cure from cases like this?
Well, I think can we just use the cancer analogy here? So when people have cancer and they're treated for their cancer, they go into something called remission, and that remission can last a day, a week, a month, a year, a lifetime. In that case, what we have is a situation where this child, soon to be, as they grow up and get older, will continue development, and the question is, will any residual virus in their body rebound? We have this fundamental problem, is we cannot go and analyze every single cell in an individual to see if that cell has HIV in it. And based on other cases we've had rebound, including the Boston patients that were reported a couple of years ago, where it looked like there was very little or no virus in their systems, they did all ultimately rebound. So remission means that they are stable at this point in time, but that doesn't mean it will last.
About the pros and cons, we have in pros, verifying HIV genome to give a prognosis of infection on the child, giving prompt treatment to the child without locking on T-cell count. And the cons, we have negative result if HIV is still not rebounding because of normal T-cell count and the bad immunologic system.
I'm Dr. Mark Block. I'm one of the directors of Holsworth House Medical Practice. We're a high HIV caseload GP practice in inner city Sydney. Commencing treatment is a big step for a patient because it involves a lifelong commitment to be on treatment. Treatments have advanced considerably over the years. They're very safe and effective. And there are some guiding principles in terms of treatment. Because of the results of the START study that have been released very recently, this has been a large-scale global study that's looked at the benefits of starting therapy in patients with normal immunity, normal CD4 count above 500. And it was a bit unclear about whether there would be any benefit in this, but the START study has actually shown a 50% reduction in patients who actually commence therapy with CD4 above 500 in terms of risks of progressing onto AIDS or dying or developing serious non-AIDS complications. So based on this, the recommendation is now that every patient is recommended to commence antiretroviral therapy irrespective of their CD4 count to reduce the risk of progression of HIV. It's a very individual decision, and one of the key factors is that the patient really needs to be ready to commence therapy. For example, if a patient has got a fairly chaotic lifestyle, there might be some factors that actually have to be addressed before they can commence therapy. They might have to have drug and alcohol issues or unstable housing resolved before they can feel comfortable about commencing therapy. All HIV treatments involve a combination of therapies, and it's usually 3 drugs are used in combination. Sometimes they're co-formulated within a single pill, sometimes they're separate. It depends on the particular needs of that patient. The cost of therapy is subsidised by the federal government. So in terms of what to start a patient on therapy, firstly, before a patient starts therapy, it's routine to do a resistance test to determine whether there are some drugs that the virus is not sensitive to, and that can determine what options there are in terms of treatment. The Australian guidance of the DHHS guidelines makes some recommendations in terms of what are the recommended treatment regimens to start a patient on. There's certainly been a shift towards starting patients on integrase inhibitor therapy together with 2 nucleoside analogues. That would be the standard treatment for initiating a patient on therapy. Given the results of the START study, the recommendation is that all patients with HIV, whatever their CD4 count, are recommended to commence antiretroviral therapy to prevent the progression of their HIV infection and the risk of complications. A discussion needs to be had between the doctor and the patient to assess the patient's readiness to commence therapy, to discuss the issues around commencing therapy, because treatment needs to be lifelong, and also to discuss the particular patient considerations, what their other conditions are, and their general health needs.
About the issue applied in Ecuador last 2 years, more than 2,000 children were examined to diagnose if HIV has passed from mother to child and is still in discussion. The long lapse of time which retrovirals are used to control the viral charge of VIH after the birth. So in conclusion, we have the child didn't have symptoms or signs of an acute retroviral syndrome or incident illnesses, including Epstein-Barr virus infection or cytomegalovirus infection, and had not received any backgrounds. Thank you.